Hello, everyone, and welcome to the How is Telemedicine Transforming Care panel discussion at the HealthTech Rapid Conference April event, hosted by the HealthTech Networking Club. I'm Lindsey Williams, founder of Corylus Consulting and co-founder of MyUTI, and will be your moderator for this panel discussion. The monthly HealthTech Rapid Conference events are organized by the HealthTech Networking Club, an exclusive networking club that brings together influential members of the health tech community. Our Rapid Conference videos boast 10,000 views on both YouTube and Facebook. So if you'd like more information on the monthly HealthTech Rapid Conference event series or the HealthTech Networking Club, please head to the Bene Studio website. To all our members, if you haven't already, we urge you to leave a comment in the general Slack space about our topic of the month for a chance to contribute to the Health Tech Guide. More details of this are available in Slack. The link to the Slack channel can be found in the Zoom chat box, so please leave any feedback or comments on the panel discussion in the general chat on Slack. Before we begin our panel introductions, I'd also like to remind our panelists to please mute all devices, including Slack notifications, for the duration of the session. Now, I will ask the panelists to briefly introduce themselves. Dr. Muto, do you mind if I start with you, please?
Hi, my name is Dr. Paula Muto. As I said, I'm a surgeon, I'm a vascular surgeon outside of Boston. I'm from a whole family of surgeons, and I am now the founder and CEO of a disruptive healthcare platform providing increased access to care for transparent price. So I'm very excited to be here for this panel.
Thank you so much. And Dr. Nina, will you go next? Okay, we'll go back to Dr. Nina. Balint, will you please pop in quickly?
Sure. Balint Bene, CEO of Bene Studio, and I'm following this telehealth evolution and the revolution from the technology perspective, technology side. So I would like to bring that experiences into this panel to share with all of you what I can see from the technology aspect.
Wonderful. And Cristin?
Hi, I'm Cristin Dickerson. I'm a practicing radiologist in Houston, Texas. I have Green Imaging is my company, and we offer affordable MRIs, CTs, PET CTs, ultrasounds, all medical imaging exams across the country. We have a network of about 1,400 imaging centers. Our sweet spot is employer health plans. We can save these employer health plans sometimes up to 10% on their medical imaging, on their total healthcare spend, and 60 to 70% on their medical imaging spend. And we are actually working with Dr. Muto on UBERDOC, and we love that partnership. And just really excited to be in this space of emerging consumerism, both for employer health plans and for individuals.
Thank you. All right, Dr. Nina, let's try again.
Can you hear me now?
Yes.
Thank you. Sorry about that. Yes, so my name is Nina Maouelainin. I'm the founder of Lung Health Services. And we are actually a turnkey service that is based on a virtual platform to be able to allow access to lung cancer screening, diagnosis, and therapy to all patients internationally. We hope to be able to help not only other physicians, but as well as patients directly in hospitals to allow the virtual platform and telehealth to battle the lung carcinoma and hopefully decrease the mortality and cause a stage shift.
Thank you. So obviously talking about how telemedicine has transformed healthcare is a little bit tongue-in-cheek because we can all see the myriad of ways that, especially in the last year, year and a half, healthcare has shifted. Specifically for the context of this panel discussion, we're going to talk about how telemedicine has transformed care in three specific areas. The first being how telemedicine has impacted or transformed the doctor-patient relationship. The second being how it has increased access, and the third being how it has decreased costs. So, to start, I had a really great discussion with Paula Muto the other day in preparation for this panel, and she brought up some really amazing points about setting the tone of how we're defining telehealth. And so, Paula, do you mind kind of just recapping a little bit of that? I think you had some really great points just to start the panel off with how we're defining telehealth to begin with. Paula, I think you're on mute.
Sorry. I think, when you think about telemedicine, telehealth, it's really been part of our practices from the beginning of time, or at least since the invention of a telephone, right? Because after all, doctors are committed and obligated to follow up with their patients. So if a patient would call us in the middle of the night with a complaint or a complication from a procedure, or we'd have to call them with a test result, that has always occurred. And that's part of being a doctor. You kind of have to accept that. As we're moving forward and we realize all the obstacles to care and the efficiency and the idea of bringing patients in, and as the technology improved, where we're not just on a telephone call, now we can talk to a patient, now we can see them in their home environment. I mean, just think of behavioral health, how it has changed the way we connect with patients. I think that now that phone call has now become something more. And so when we talk about telehealth, you have to think about what we're talking about. A year ago, telehealth suddenly became important because it was paid for. But a lot of telehealth still occurs with that phone call with a doctor checking up with a patient instead of seeing them in the office, and that's now monetized. So we've essentially kind of monetized the phone call, but that's not what the technology is really capable of. The technology is now bringing us to a whole new way of connecting to a patient, extremely intimate, patient, doctor, patient, a video conference, a second opinion, bringing expertise that may not be in your neighborhood, but is now accessible to you. And that's what like UBERDOC is excited to be part of, because what we're looking at is, when we started our platform, it was patients, doctors, in-person visit. Long before the pandemic, Milton Chen, the founder of VC, who is the person who created video conferencing for the space station, he came to us, he said, "Paula, you're beautiful." I said, "Wow, I'm beautiful." He said, "We want telemedicine to be in the hands of the end user, the doctor." Okay, and right now it was being utilized as kind of a call a doctor, talk to someone over a phone maybe, or these one-offs. His vision was to save orphans in the Philippines, right? Be able to connect patients to doctors with expertise to help. So I said, "Well, Milton, sure, whatever, maybe my psychiatrist will like it, but what is a surgeon going to do with telemedicine?" And lo and behold, we started introducing it, and then look what happened. Now I see a number of new patients through telemedicine. I think we're all using it. We all have a virtual examining room. I think any doctor in practice, from beginning to practice to the end of practice, will need to have a virtual examining room. So within a year or so, we've now embraced the technology, and it's just how the possibilities can be utilized. So I think that's kind of what I see how telemedicine has kind of the definition of telemedicine evolving.
Balint, you had a great term for this. You said telehealth is like the glue, right? And this first version of telehealth is like the base version of what we're seeing in terms of what the technology is actually capable. Do you mind speaking to that a bit?
Yeah, it's really exciting. And as Paula mentioned, the beginning of telehealth was the phones, or even before that, written mails with recommendations. But nowadays, we are still in the middle of really fast evolution. And now, during the previous years, what I saw is that we have really stable foundations. Like we definitely have a virtual tube between the patients and the doctors, and for this first generation of telehealth, we can see the real-time consultations, which is a fantastic thing because people don't have to travel. And on the other hand, it's really important because it's a foundation which we can build on, because doctors and patients both had to be educated with this new digital aspect and behavior, and it's not that trivial that we should do the doctor visits virtually. And fortunately, today we are at that stage when a lot of doctors and a lot of patients are comfortable with this technical environment, and now we can build on top of this fundament. And the next generation of telehealth, as I can see on the market, is more and more special solutions, which are solving special needs, and not just live consultation, but other solutions as well. For example, connecting the IoT at-home devices or IoT wearable devices, which is not that obvious, into the care. It could increase the efficiency of the whole system. And on the other hand, what's still a big problem is doctors are really busy, and they are really busy even if the consultation is remotely, not on site, because they have to spend the same time with consultations, just not in person, but in front of a screen. So it's definitely a challenge what we have to solve with different solutions, and since the need is really big for this solution, we can see more and more solutions like AI applications, where 1 minute of doctor's work is more effective than 1 minute of spoken consultation, because they can focus on the expert side of the work, and a lot of administrative work, a lot of preparation, a lot of related work can be done by software help. So it should be definitely the next phase when doctors can spend their time even more focused on that field where they can have the biggest impact, and the telehealth solutions, including IoT and AI integrations, can help them to be even more effective than just in a virtual visit.
Yeah, I think those are really great points from a technical perspective. And, Paula had mentioned in our previous conversation, just the value of that intimacy. And she mentioned again here today. And actually, Cristin had a really great point around this of, for all the technology, the most valuable piece of this is the actual relationship with the physician and the value that brings that's so intangible. Cristin, do you mind speaking to that a little bit more, how you've seen that through your work?
Sure. I really have the most unique radiology practice in the country, I think. And, for years, radiologists have been sitting in a dark room, just spitting out reports to referring physicians. This model where we have a great secure messaging system where we can communicate with our patients gets me involved in the patient care much more easily. So my concierge service, comes to me. This is, an unusual PET CT scan. It has a radio tracer that we don't typically work with. How do we go about getting this scheduled? Where do I look, for a facility that might do this? The patient is asking why this is going to cost $5,000 and not the typical $1,400 that we charge for a PET CT. I can communicate and let them know that this tracer, itself is going to cost $4,000. At a hospital system, it's going to cost $20,000. I can, if I have questions, we read about 60 to 70% of the exams performed in our network. And so, if I have questions for a patient, I have the luxury of being able to communicate with that patient, ask them if they've had prior surgery, if I have something that looks really strange, if they had prior surgery on that kidney or whatever it is. It really changes healthcare. My background is with multi-specialty groups where I actually had the luxury of working with other doctors, but I didn't have the hands-on with the patients. And this gives me the hands-on with the patients that I think really makes a big difference in diagnostic accuracy.
Yeah, diagnostic accuracy. And then I would also say the patient experience and the patient journey. And Dr. Nita, maybe you can speak more to that since, specifically with your endeavor, lung cancer or any kind of oncology, that in particular is an area where the patient journey is so important, and that relationship between the physician or the surgeon and the patient does become even more intimate because it's, just the longitudinal nature of it, right?
Absolutely, you hit it right on the head. I mean, the telehealth access has tremendously and actually rapidly changed delivery of care specifically for the oncology population. Just to give you an example, like having a 65-year-old who worked 2 jobs, who was in a rural area, that suddenly has an abnormality, instantly someone checked X-ray. The journey used to be finding the time off and then drive, going to specialists, interventional pulmonologists not around the corner all over the country. Find someone that goes with them, or they go by themselves after they get the referrals. Finally, they need to find parking and getting in and so forth. Now, it's literally within a touch of a screen. So what ends up happening, all they have to do, and we guide them through it, is to have maybe a secure connection, a phone, a computer, and you don't even need to have that because you can ship them whatever it is that they need for that connection. And that's how we actually have evolved within our company, is to be more efficient and, more importantly, being effective in impacting mortality and access to care. So if you ship, God bless Amazon, right? If you ship directly a package with all the requirements and they're able to actually be walked through with a specific team and pipeline it, and be able to log in comfortably wherever they are without having to worry about all the tertiary and secondary impacts with regards to how much money they're spending, how much money they're going to be losing. And when you look at the data, the majority of these patients are in rural areas. I mean, if you are in the city, in urban cities, you have access, although it is bottlenecked pretty much for lung cancer access. But if you are home, you're able to talk directly to your physician. You're able to fill out all the paperwork that is needed to be able to undergo any type of testing. But more importantly, the family is able to be there. You're able to invite as many as possible, whether they are physically next to you or all the way in India or Japan. It doesn't really matter. And that's priceless, specifically because of the nature of the disease. And anyone that works in oncology or medicine in general, the social aspect, the mental aspect is absolutely crucial in being able to beat the disease itself. The impact is also from the effectiveness in having the teams, the multidisciplinary teams, able to log in and have that multidisciplinary approach. So the patient is not going from, okay, well, this is what you have, pick up the phone, schedule this patient or that patient. That is not how it works anymore. Not a problem. Let's get the radiologist. Let's get the oncologist, let's get the pathologist, the social worker, the palliative care, all in the same Zoom session. And that transformed the relationship from being mechanical to becoming human. And holding their hand is absolutely a must to beat lung cancer. And I'm very sure every other entity.
Yeah, I think those are all really great points. The transformation of just being able to sit in the living room and discuss your cancer plan and your path forward, surrounded by your family in the comfort of your home, is massively game changing for patients who are engaging on such a long and difficult journey. I know you mentioned something specifically about access, and I think that's a really good point because Paula, you had made a point about this being an inventory problem often when you're talking about specialty care. And there's actually a really great conversation in the chat too, that's not just about access to telehealth and specialists, but also about access to all of the ancillary things like diagnostic testing and stuff that comes from it. So do you mind touching a little bit on that and maybe even a little bit about how UBERDOC is kind of tackling some of that problem?
Sure. So access to care what does it mean, right? We all, for the last decade or so have had, or longer, have had, insurance that, every citizen has to have health insurance, right? So, hey, we have health insurance, we should be able to access care. So, but it became so convoluted and it became so expensive that that we've actually, it's now a challenge. I was thinking the other day that to get to a specialist is kind of like, imagine we're in the tower of a castle, and the first thing you have to do is get through the army in the front, and then get over the bridge, and then get over the moat, and then go through, and then get up the stairs, and finally you get to the specialist. I mean, that's literally the journey patients take. And you take a patient who's just needs sort of maybe a routine eye exam, and then you take that patient that has a new abnormal mammogram on their routine. I mean, you think about the anxiety and the concern, and it's just not fair. So one of the things that I had always thought about when it came to access is that, why is it that way? And so much of it that way has to do with insurance. It just has to do with payment. So if we took payment out of the equation, well, doctors working for free, well, that's ridiculous. It's not what we're saying, but doctors working for the patient, yes. And what if we made that price a little lower than commercial insurance, but still above Medicare to be legal, so it's fair? So we don't make a concierge price. I mean, Dr. Dickerson doesn't charge 3 times for that x-ray. She charges what she's going to be able to actually do the x-ray with an appropriate margin. So you look at that and say, okay, we can do that cost of care. We are all in this kind of game where we overcharge to collect less. I mean, it doesn't make a lot of sense. So what if we made a transparent price that was affordable, that was legal, and improve the access? So it's kind of flipping the equation on what exists. And that's basically how we created our model. And when you think about that patient who needs to get to a cancer specialist, my brother's a GYN oncologist at the Dana-Farber Brigham, very hard to get to. To get to my brother, you'd have to call me, phone a friend, have the right job, have the right insurance, have the right employer, have the right everything. So it's not fair. Why shouldn't everyone have equal access to the best? And if you make that price point affordable, then everyone. So you really democratize access to care. And essentially, patients need to get, so it's that inventory issue. Patients are in need. And there's all these doctors sitting around with empty spots in their waiting room because we have a no-show rate. Sometimes it's 40%. So we know we have capacity. It's the same thing that I think Dr. Dickerson can speak to this, the concept of inventory, of capacity, of machinery that's expensive, that's underutilized, and patients that need it. How can we match that? Well, that's where technology comes in. Technology solves this problem because now you can match a patient to a doctor. And it's like, we're open table for doctors, right? That's what UBERDOC is. We're matchmaker, ticket master, however you want to say it. So if we can get a seat or two in every waiting room, we can say, okay, these seats are put aside and those patients get to pay cash for those seats. And then let the market drive it. But it's matching that inventory, that availability, and that skill set, because we have such smart, great people out there that can solve your problems so easily, because we're not that smart as specialists, but we do the same thing all the time. So we get very good at looking at the same thing. So that's kind of how I view the word access. And when you add telemedicine into the word access, it just increases your radius. But remember, healthcare is always personal delivery. You can't just wave a magic wand and expect that, a doctor 1,000 miles away will necessarily make you better. They can help you on that journey, but that journey still requires that local doctor, that local radiologist who might have to do the biopsy on the patient, or the doctor that's going to take care of you. So this is just part of a puzzle that works together. And that's why the doctors need to be at the forefront of this technology, because we have to guide it, because it's a tool for us to utilize.
Very much so. And Dr. Dickerson, do you want to pop in and kind of comment? I know Paula mentioned that you have some experience with this. You could maybe add to that.
Yeah, somebody posted in the chat about, just testing in general for telehealth. That is, it's going to be an emerging market. And the problem is that existing ancillaries are set up to work with insurance. A lot of times when my patients who are have catastrophic coverage or are on a health sharing ministry or just don't have insurance try to approach this type of facility, they're turned away. A lot of time the health sharing ministry, they show that card and they say, we don't take that insurance. And even a lot of employer healthcare plans that are now doing reference-based pricing or have no network, a typical imaging center will say, we don't take that insurance. And the employee is instructed to say, hey, but no, we don't have a network. You can, call, you'll see what my benefits are, or I'm paying cash, what is your self-pay rate? In Austin, if you approach ARA, it takes you like 2 or 3 days just to get a cash rate on an exam. It's craziness. And, so we believe in transparency. Our rates, we have 1,400 centers and patients frequently don't know what exam they need. We do have sample pricing on our website. The problem is if we publish our whole deck of pricing, patients don't understand. They don't understand that not every facility in town even offers an MRI. Some of them only have ultrasound and mammography. And but we have concierge service that will respond to them by secure messaging. It's like a text to the patient and get them that price very quickly. So, I think having options out there that are geared toward kind of the new healthcare marketplace and toward working with telehealth, I think is going to be a game changer. And, we try to be that connection for medical imaging, and we're working toward radiation therapy is something that we're working toward adding to our network as well. There's no reason that we can't offer that nationally. And so that's kind of our next step. And we may do some additional, ancillaries down the line. We already have the infrastructure to provide these for patients. So it's kind of a natural step for us to continue toward more ancillary testing.
I think that's a really important point too, and it was brought up in the chat as well, but you had said to me when we were on the phone that sometimes there is with consumers, because so much of this with telehealth is to a certain extent relying on the patient to be a consumer and to drive their care in a way that's different, not necessarily bad, but just different than the traditional healthcare system, right? To Paula's point of over the moat and the bridge and everything else. And sometimes there can be misguided consumerism on the difference between shopping price versus quality, right? Because there is a lack of transparency around healthcare costs, true costs. And I think that that's really important. And especially, and Dr. Nina, I'd love your take on this, because especially when you're dealing with oncology, but then even more so when you're dealing with underserved communities or communities that aren't getting access to care that need it most.
You're absolutely right. And that is the biggest challenge is for right now in the world of oncology and more importantly, diagnostics, you really depend on insurance contracts and what's offered in your local hospital. And that was the first challenge identified by us is our technology is usually bought by hospitals, and therefore if the hospitals cannot afford it, the patients do not have access to it. Well, if you reverse that equation and instead of making it dependent on what the hospital has to offer, but rather what the patient chooses to actually get based on the mobile service we offer, you are able to bring to them whatever they need and be able to actually work with them and be transparent about what the actual prices are. As my colleagues here actually explained, I mean, from the green imaging standpoint, it was absolutely amazing to be able to see a patient that doesn't have insurance. We do offer, we do see everyone and anyone, regardless of whether they have insurance or not. We really a mixed direct service as well as insurance-based. And if they cannot have a coverage for a CAT scan, and instead of wasting hours to try to get an authorization for someone who clearly needs a CAT scan, it's so much easier to just go on, and we have like literally access to green imaging, and they do all the work, and they are very clear and very accessible, affordable, and patients end up using it, and they love it because they don't have to worry about the intricacies and details and lack of transparency from the pricing standpoint. Similarly, with UBERDOC, you're able to just go in there and say, okay, I am worried about a lung carcinoma. Where can I have access? And instead of actually being on hold with their insurance companies for hours on end to see who the qualified physician or center is, now you put it back in their hand and they're able to shop around and, more importantly, decide for themselves without having to be at the mercy of administration and insurance companies.
Yeah, I think that's a really great point. Some other things that are popping up here in the Zoom chat, questions around, with the testing and the infrastructure. And Balint, I'd love your take on this. But, one thing that I know Paula had mentioned in our conversation was that a lot of these systems don't integrate with each other, and that's probably not going to change in terms of EMR. Like we've built this behemoth, and it is what it is. It's a very large ship to slowly turn, if even possible at all. But from your perspective, what tools does technology allow for us to improve on versus what is kind of something that we're just going to have to work around?
Yeah, it's a really exciting question, and let me join to Dr. Nina that nowadays we are seeing more and more options, which is a good thing. But on the other hand, it has its difficulties as well, because we as patients have to be prepared for that choices, which is not often that obvious. So it's a double-edged sword. And what I can see is that this technical evolution helps to the patients to make their decisions more wisely. And what I also can see is that patients are more and more transform the services themselves, because if there are a lot of patients who can choose from an alternative and change to an other service, then that providers must be in the competition. So it's a big change from that situation when there were less alternatives. So this perspective is changing, and to serve the patients and to have more and more clients, the providers must improve their solutions as well. So if patients would like to have integrated solutions, and if patients can manage their money as well, then with time the systems will provide that accesses, because they would like to have their patients. So I can see this trend mainly with smaller services, but bigger players also can see this, and they join into this movement. So, for example, we can access to more and more open APIs, and we can provide more and more integrated solutions using core systems, because it's beneficial for both parties, for the new niche players who would like to serve special needs and who would like to provide really high quality user experience, and useful for the bigger platforms, bigger providers as well, because they don't have to invent risky new services. They can cooperate with more innovative and risk-taking players.
I think that's great. Baraka commented in the chat here, specialty care is really the growth area in telemedicine in 2021. What do you think are some of the real opportunities as well as potential dangers of specialty care via telemedicine? Paula?
Specialty care absolutely is a growth area. It's what a lot of the players, shall we say, the direct-to-consumer players have all been kind of in this, wellnessy space. Men's Health verticals, the Hims and the Romans, very big direct-to-consumer. But now they say, oh, let's get into chronic disease, right? Okay, great. You have 150 providers that are on salary, that they can answer phone calls and write prescriptions. But are you going to write a prescription for Humira? Are you going to write a prescription for, for an insulin? You can't just write the prescription. You have to follow the patient. It's a chronic disease. So it doesn't make a whole lot of sense sense to do a one-off, right? So specialties, just telemedicine is just part of everybody's practice. I mean, that's what you have to understand. It's there. And the doctors haven't figured this out yet, that they are their own teledocs, right? they literally are. So what really changes? Nothing. We are doctors. We take care of our patients. We're just using another tool. And you have to understand that that's where it is. Now, the beauty of the tool is that you, again, because you're sourcing your talent beyond your 5-mile radius, right? Because now you can technically connect to a patient in another state if you're licensed in that state, potentially in another country if you are like working with second opinion networks. So those go beyond lines, but that's a very different model, right? And again, the doctors are able to just do that. Again, my feeling is telemedicine should always, for new patients, should always sit in the cash model. I mean, telemedicine's not expensive, right? And it's not, and I mean, we haven't gotten to the discussion of the cost yet, but certainly the doctors can provide these services directly to the patients without a whole lot of middle people involved. So I think specialty telemedicine is here. It is here. It's just, like I said, the doctors haven't noticed it yet. They're incorporating it into their practice. The patients, given a choice, this is where the issue comes in, direct to consumer models. How do you differentiate, the one-off 20-minute phone call, a 10-minute phone call, and, prescription writing to your doctor? Well, your doctor should be available that way too. So that's kind of our vision, is that specialty care is going to be there, and it's going to be there for the patients. I do want to just make one comment that Balint was saying about the data collection and the need for integration. One of the challenges with integrating data is the kind of data you're integrating. The information that we need to treat a patient is very much like sharing an X-ray and image digitally, really transformed the way we access our imaging and our data in our laboratories. Most of the complications occur on the other side of the data, which is the billing, the insurance, the nuclear code that translates into the payment. So a lot of that disappears when you are in a direct pay model. It just melts away. It's simplified. So a lot of times the information sharing becomes much, much easier when you remove that piece out of the equation. So all that data needs to be collected because insurers and CMS and regulators need it to reimburse you. But if it's a direct pay transparent model, none of that data needs to be collected. So it actually, you're just focusing on the patient data that will inform your decision. So I just want to put that out there, that the kind of stuff that we're talking about really transcends networks. And ultimately, patients will carry that data with them. And I believe, Dr. Dickerson, your patients carry their own images, right? They have an app that carries their own images, so that you can actually, you hold your own data, which is probably, we're probably going to be the future. If not, it's here right now, where the patient carries their information.
Yeah, Johanna had a great question. This takes us right into our last topic of the panel, which is, will there be a risk even for an import of low-cost telemedicine for patients not having the right insurance? Or is telemedicine, as you describe it, a solution through opening, as someone said, open spots from no-shows, able to serve more patients at a better price? So, I think really the question is here, from a cost perspective, is this going to be an additive model, or is this going to be something that's going to be supplementary to practices? And Paula, you actually told me, and I was quite surprised, that a lot of the big academic institutions put limits on their telemedicine, only limiting it to existing patients. And I think that's actually another interesting part, and plays into this cost conversation of where are these boundaries going to be drawn with direct to consumerism and the different challenges that can arise, even with cash pay, although it increases access, versus, staying in a reimbursement model.
I think it all comes to value. Right, it's all perceived value, right? Connecting with a pulmonologist is going to discuss your cancer options is one value, and doing just a follow-up visit to get a prescription for a UTI is another one, right? So people are confused, right? And this is a new marketplace. However, if you think about it, the concern is that it's almost like you can't beat them, join them. You can't push back on this technology. It's just not going to happen. Patients are going to look for convenience. They look for it now. People just pay, and they will pay for convenience because they're doing that now. So you can decide that we're not going to be convenient. We're going to be that restaurant that's really hard to get into, and you have to have reservations 10 weeks in advance, and maybe that works for you. But honestly, if you can't get in that restaurant, you're going to go across the street. So big hospitals networks have to understand where the consumer is going with this. And at the end of the day, collecting revenue is important for everyone, doctors, individual practice, multi-specialty, and large network hospitals. Cash flow is important for all of these institutions, and they work in a deficit all the time. And remember, hospitals have to take care of anyone that comes in there. So they're constantly working at a cash flow deficit. So introducing a cash model, after all, you collect copays, you collect it. What if you just collected it up front? And telemedicine is the perfect opportunity to do that because it isn't very high overhead and it's high patient satisfaction. And for the convenience of not having to go to the hospital, the patient knows, oh, you know what, I'm going to pay a little extra to go and do this. Trying to put it in the insurance realm, insurance pays like $20. It costs you $30 to bill it. So it's not really a good business model. So it doesn't really work well on the other side of things. And I think so when you start really looking and, when you think about like some of these insurances that cover, you go to the employer-based insurance, it's like fantastic plan. We're going to give your employees telemedicine. So you pay the $20 telemedicine visit, but you don't pay for the $2,000 CAT scan. That's not a very good deal, right? So let's just say that, there's a lot of players in this space that will make sure that you're paying maximal dollar for little delivery. It's like deductibles, like pay a lot of insurance and pay a lot of deductibles, right? It doesn't make sense. It makes sense for the insurance industry. We're not about that. This is about connecting, using technology, and taking advantage of an absolutely emerging marketplace. And you either decide you're in it or not, but you can be in it a little bit. You can have a supermarket aisle for cash. And if you do not have a transparent price supermarket aisle, no matter who you are, whether you're an individual doctor in a tiny town or whether you're the biggest institution in the country, if you don't have that transparent cash aisle, you're going to lose the customer. I mean, that's just what it comes down to because the choices are too much out there, and let the consumer drive this. And that doesn't mean insurance disappears and all that, but you just have to have an option. And that's really what we're talking about here today. And telemedicine is such a perfect place to put that option because it isn't expensive, it's high value for the patient, super convenience, and the price point is affordable. But to try to make insurance pay for telemedicine, that's where it's going to all break down. It's not going to be worth it. It's not going to be worth your billing person is going to take more than the telemedicine reimbursement.
Yeah, I think that's interesting. I know Dr. Dickerson and Dr. Nina, you may have to straddle the fence a little bit more in dealing with both cash options, but also reimbursement models. Do you mind speaking to this in terms of how you have seen telemedicine decrease costs in your systems?
Well, for us, we do not take traditional insurance. We did go in network with some of the Affordable Care Act plans, and that was a disaster. Physicians spend about 30% of their revenue to collect 70% of what they're contracted to receive from insurance companies. It is, as Paula says, a losing battle. And so we very quickly dropped out of those. But we do work with health plans. So I was president of a multi-specialty group in Houston, and we were self-insured, meaning really, although Blue Cross Blue Shield was our network, it was our credit card that was paying for these exams. And so we pulled everything we could out of that Blue Cross Blue Shield plan, direct contracted it for it. Our employees, if they used our services, it was zero out of pocket. If they used some other strategic partners, it was greatly discounted from what their contracted rate would be. We pulled everything out of that healthcare plan so that basically the Blue Cross Blue Shield plan was for catastrophic coverage. That's really what needs to happen in the employer space, and it is what's starting to happen in the employer space. So we are in health plans, but we are the preferred network. And I don't send a claim form to the employer, to the school district, or whoever it is. I send an invoice that has the information they need to verify that that patient is theirs and that the patient had this exam at this price. But it's not all the bureaucracy and all the red tape and literally the red HCFA 1500 form. It is a much cleaner and less expensive and less cumbersome way to do business, and it works great.
So from our standpoint, we are a mixed model, like I said, direct service care versus insurance plans. We are in the process of working on health plans and definitely catastrophic coverage. The challenges are in the surgical subspecialty is to proceed with the actual diagnosis, biopsies, and everything else. You have to actually complete it in a hospital setting unless you have a surgical private setting where the patients can come in and you work with them on a payment plan to be able to actually ensure that the surgery is completed and they pay it accordingly and affordably. It is a challenge definitely nowadays in being able to complete that in the forefront of interventional pulmonology and actually using technology that is just FDA approved and certain insurances don't even cover it and you have to battle with them. Definitely a challenge for the cash flow. And that's why we are actually trying to collect enough data to prove back that it would make much more sense to cover the actual minimally invasive surgeries and biopsies rather than to refuse it, delay it, and you end up having the patients showing up to the ERs and coming back around the clock to ultimately have much more expenses and being diagnosed with stage 3, stage 4 that requires chemo, radiation, and ultimately palliative care. So in the world of telehealth, I think the upfront diagnosis and evaluation is a must with a cash model. And ultimately, the surgical part is going to be the challenging aspect from a telehealth standpoint because obviously you have to be present, you have to be in a hospital. However, hospitals are not completely against the mixed model and they understand the necessity of it at this point because of, as I stated earlier, the efficiency and the upfront costs that you can avoid with a personnel status or personnel and staffing. If you have an in-person visit, you can definitely see easily 25, 30 patients without having to worry about rooming them and doing all that. You can just go straight and analyze whatever it is that you need as far as accessing data and accessing records. And just to that point, I wanted to actually focus earlier on the fact that right now, the majority, as physicians, we keep data on our EMR to be able to have a fluid process in care. But I think ultimately the future will be in the patient literally having all their medical information in their pocket and being able to choose and use that data and share it with whomever is providing the service via telehealth. That, I think, like you said, is a big boat to move because right now everybody has their own little EMR system. But to be able to effectively impact diseases and have the quality care, I think.
Uh-oh. We lose Dr.
Oh.
I think we lost Dr. Nina. Dr. Nina, we lost the last little bit there. I think you're coming in and out, but it's actually time for us to wrap this panel up. So I'm going to ask each of the panelists to provide kind of their 60-second key takeaway for all of our listeners today on how telehealth has transformed healthcare. So Balint, I'm going to start with you.
Yeah, thanks. So from my perspective, as I can see the technology, Moore's law, which says that the calculation power of hardware doubles in every 2 years, is really can seen in digital health and telemedicine as well. So as we are having more and more technical opportunities and fundamentals, we can build on them special solutions as well, and we also can can work with the patients and doctors' experiences as well. So we can create newer and more user-focused solutions in the near future.
Thank you. All right, Paula, 60-second takeaway.
I think you think about telehealth, transforms access to doctors and access to care. It doesn't change what we do as physicians. I think fundamentally, our mission is the same, to take care of patients. Telemedicine just gives us a new tool, a new way of accessing care. And I think that's really important because ultimately, to me, medicine is very much rooted in a peer-to-peer transaction, a peer-to-peer relationship. It doesn't fit well into high corporate models. It never fit well into networks and big box store. It just doesn't. Every patient's individual, and we know from everything that's happening in medicine, oncology, things are so individualized. Medicine is not a one size fits all. It's very, very personal, the most personal thing. So I think that telehealth just transforms the way we access our patients, and it reminds us of that primacy of the doctor-patient relationship. And it's a golden opportunity to take this moment as a watershed to turn the boat around back to what's important, which is the patient and the physician, and take the resources in healthcare and direct them to the patient and the physician, and get rid of all the nonsense in between that is just creating a lot of data, a lot of bureaucracy without a lot of value.
Thank you. Dr. Dickerson?
Well, I'm responding to the chat because I think this is something we missed in the conversation, which is direct primary care. And the direct primary care movement is sweeping the country, and it's subscription-based primary care. And so the last question about who will be coordinating care, employers and individuals are investing in subscription-based primary care across the country now, just for that reason. It saves employer health plans 40, 50, 60% of their spend by, it's a different concept for them to pay up front for something. But down the line, all the way through the chain of care, through that patient's, we have to quit looking at, that patient for a year of healthcare the way insurance does. We have to think about their lifetime and the health of the workplace. And that is an investment employers and individuals are making that will also be game changing.
Thank you. Dr. Nina? All right, I think we have lost Dr. Nina. But we are having amazing questions asked in the Zoom chat. I would love for those to transition and this conversation to continue in the Slack channel as well. Please join us next month on May 27th for our next Rapid Conference event with a focus on AI and machine learning. Until we meet again, if you'd like more information on the monthly HealthTech Rapid Conference event series or the HealthTech Networking Club, please head to the Bene Studio website and follow Bene Studio on social media. We're now going to have a 3-minute networking break to talk to each other on Slack. And once we return, Sandra Miller will be your moderator for the HealthTech Startup Award session. Networking Club members, please join me on Slack for more networking and a chance to comment on the topic of the month. The link is in the Zoom chat, and to everyone watching the live stream, stay online and we'll be back shortly.
Hi, Sandy.
Hello, everyone.
Hi.
We're ready to go. So let's kick this off. Welcome to the HealthTech Startup Award at the HealthTech Rapid Conference. This is our April event that is hosted by the HealthTech Networking Club. My name is Sandra Miller, and I am CEO of Runway Innovation Hub in San Francisco. And I'll be your moderator for this startup award session. It's important to understand that the rapid conferences that we've done, these actually get a lot of traction after the event on YouTube. We've had 10,000 video views on both YouTube and Facebook. So that's tremendous, because I think for startups, it really helps you get more exposure, certainly, but it also, you can go back and sort of look at your pitch. You know, we're always learning every time we pitch. And so it's so helpful to go back and be able to see the recording basically and see how you did. So let's get today started. We have again a terrific panel of judges, which includes Dr. Gary Goldman, who is CEO at the Global Health Impact Network. We have Chris Saxman, who's a board member with Nymbl Science. Dr. Edgar-John Vogt, and I apologize if I'm not pronouncing your last name properly. Dr. Edgar-John Vogt, who's the company scout at the German Accelerator, which is a terrific organization. And Balint Bene, of course, who is founder and CEO of Bene Studio. I'm going to actually ask each of the judges to briefly introduce themselves. And let's start with Chris Saxman. Chris?
Hello, good morning, and welcome. Nice to meet everybody that I haven't already met. So I have been in and around digital health for about 8 years now. I helped to build a telemedicine company called SiriusMD from the point where we were basically just 2.5 co-founders. I was the first non-founder to join, to the point where we're now probably over 9 million covered lives. I left there in August because I'd kind of done what I came to do, and I'm now mentoring a variety of different companies. I am putting a lot of effort and thought into what really we need to, what are some of the big issues in the industry, and how we might fix them. And I'm excited to be here.
Terrific. Thank you, Chris. That's great to have someone who's been on the startup side as well. That's always a plus, I think. And someone who has seen this rodeo from many perspectives, including the entrepreneur perspective, is our next judge, Gary Goldman, Dr. Gary Goldman. Gary?
Thanks, Sandra. Yeah, Gary Goldman. I've got 35 years of healthcare experience as a dentist, an anesthesiologist, an informaticist, serial entrepreneur with 3 previous digital health companies, and now currently founder of the Global Health Impact Network and Global Health Impact Fund, which is a fund which is that is focused on active participation by clinicians. Most of our investors are clinical, and our due diligence process is very focused that way. And we're building a global network of clinicians to promote active participation in this digital health revolution.
Thank you, Gary. Our next judge is Edgar-John. Edgar-John?
Yeah, thanks, Sandra. Well, good morning, good afternoon from Germany. Well, my name is Edgar, and as you pointed out, I'm working for the German Accelerator, and it's great that you pointed out it's a great program. So I'm a scout and advisor for German startups who want to scale their business to the US and also to Asia. But we have a team in Boston from where we are operating and helping German startups to enter the market in the US. My background is in cell biology and developmental biology, so I have a PhD, and actually got my postdoctoral training at the NIH in Bethesda, Maryland. So I spent many years down in the DC area and know quite well the US healthcare system, and also the US research landscape. So I'm looking forward to the pitches today.
Terrific, thank you. And our final judge is Balint Bene. Balint?
Hello, everybody. My name is Balint Bene. I'm the CEO of Bene Studio. And at Bene Studio, we are developing digital products. And during the past 10 years, I've seen more than 100 products. And today, I would like to help with that experiences. I would like to share some relevant experiences, how to increase or improve such digital products. And also today I would like to learn from you, from the startups, because there are a lot of things to learn today. And with this event, we would like to help promoting your services and helping your missions as well. For myself, it's less a competition and more a collaboration, how to help these startups with different help.
Great, thank you so much, Balint. So we have 4 terrific startups who will be pitching today, and these include Edgar-John Zimmerman, who's founder of Drift Biotechnologies, located in San Francisco, Dr. John Chu, founder of iPill Dispenser, which is based in Whittier, California, I believe. Fabian Temme, founder of Medial Cooling, based in London, in the United Kingdom. And Heather Lagrippo, founder of the US Consumer Healthcare Advocacy Group, based in Birmingham, which I think means Alabama. So Heather can tell us that in a bit. So let's talk through how today's session will run. Each startup will have 4 minutes to pitch. And after the startup pitch, I will ask the judges to briefly ask any questions, maybe to clarify something that they heard or maybe didn't hear, and also to give any feedback, because we're all learning, we're all trying to get better. And then after this Q&A, we have a very fancy technologically advanced scoring system where I'll ask the judges to literally throw up a few fingers to show me what their score is for that particular pitch. And we score on a scale of 1 to 5, with 5 being the highest. And at the end of today's session, the startup with the highest tallied score will be announced as April's HealthTech Startup. And so you'll get a fabulous product acceleration session with Bene Studio, which allows you to enhance the development of your product. And if you're interested, you can also have a one-on-one coaching session with me, courtesy of Runway. And all of the startups, everybody gets something today. All of the startups are eligible for a free product boost session with Bene Studio, which is super helpful. So I would definitely take advantage of that. And we are also continuing to use the Slack channel, which will be, the link will be put in the Zoom chat. Again, just to remind you, if you're just now joining us. So please do use that Slack channel to share your feedback and praise and support for all of our startups during their pitches. Share your perspectives with the judges, and your feedback might be highlighted in the HealthTech Startup Award summary that is produced and then published on the Bene Studio website after each of those events. So let's go ahead and get started. And we will have go first with Drift Biotechnologies, Evan Zimmerman from San Francisco.
Hey there.
There. Hi, Evan. So we see and hear you.
All right. By the way, this is a beaker mug that says powered by caffeine on it. So you are not mistaken. All right, let me do share screen.
Okay, and I will get my fancy timer ready. And
Cool.
yes, it's my iPhone.
Can you all
And
see the presentation?
yeah, see your slides.
That's a yes.
So Evan, yes, yes.
Okay. All right.
So we are ready when you are.
Great. All right. So hi, everybody. Really appreciate your time. So I'm Evan, the founder and CEO of Drift Biotechnologies. I got involved in healthcare because my mother passed away when I was a teenager, and I wanted other people to have better healthcare outcomes than she did. Got involved with a lot of groups, including USC Medical School and the Clinton Health Access Initiative. And what I saw was that microbiology touches everything we do, but the testing was in dramatic need of improvement. And so that's why I started Drift Biotechnologies, to help fix microbiology testing. What we are is microbiology genetic testing software, but easy to use and fast. And this is something that's unique on the market and solves a really important bottleneck. To be clear, we're a SaaS product, pure software. We don't make a sequencer, and we don't make a sample prep chemistry kit. So what we do is provide all-in-one microbial genomics. This is in the cloud. The way it works is people upload their sequence files to from any of the common sequencers. They tell us a little bit about it in terms of what they want to do, the kind of sample it came from, and then we tell them what's in it. We also maintain and update the reference database ourselves. And what you're seeing up here is a mock-up, but we think that people are going to be making products with this too. So everything you see by dashboard, people are going to be able to do by API as well. And in addition to telling people what's in the sample, we'll help them access information about it. For example, you can see here, in the future, we'll have an epidemiology module. And we're also going to give people information about the actual individual microbes. So we can support short and long reads, shotgun metagenomics, amplicon analysis, and more. And one of the really important things I want to emphasize here is that sequencing is a technology that tells you everything that's in the sample at the same time. And because it gives you the genome, you can look for genes and then make phenotypic predictions. So drug resistance, for example, something that's super important in the clinic, it oftentimes doesn't get done because the test can take 2 to 5 days. It's an antibiogram. And here you can just look for genes or even do a machine learning classifier. So the reason why you would want to do sequencing is that it's ready for prime time. It's really fast and really cheap. And so when I looked into sequencing, I thought, geez, it seems like someone solved this problem. But the core thing that you might not notice when you just look at this is that it actually requires a lot of work. Sequencers are not turnkey. They produce data, but that data requires a custom script using one of potentially over 8,000 libraries to actually understand what it is. And so people have to hire experts. And that results in a lot of problems. It makes it hard to actually manage the exercise. And so what we propose to do instead is to have us be in the center. So you go from having to do all this stuff to just using a single software provider. Now the opportunity we think is pretty big. People use sequencing for lots of different things. It's a broadly applicable technology. Just in healthcare alone, over $30 billion being spent, and it's growing fast, 10.4% CAGR. So potentially up to a $90 billion market in 2027. And there are billions of microbiology tests done every year in addition to healthcare. And so as this technology improves and gets more widely deployed, you can see this really getting involved in areas that affect human health too, things like agriculture. Now, in terms of competition, what we do that's special is that we're very easy to use and we're very fast. So one of the things that you see out there is lots of open source tools. Most of the things that you see on here are actually open source projects, and they're mostly individual libraries that people have to work with themselves. They don't think of the whole pipeline, and so it's very slow. And additionally, because most of the things that you see here, even by private companies, are made by older legacy enterprise companies, or they're made by academics who are basically pushing a bioinformatics solution, you don't really see them be easy to use. What we are is fast because we're built by computer scientists. And our whole thesis is that the science is very good. People know how to do this. But what's not really been as advanced is the computer science, making things really awesome. Now,
so Evan, you're actually at time, so we need you to sort of
sure.
Wrap up quickly with
Absolutely.
what you're asked.
Absolutely. So like I said, we're a SaaS company. We charge per sample. we're raising a pre-seed round of between $1 to $1.5 million. Already got some really strong investors on board, and looking forward to adding some more who can really bring us over the top and help us really make an impact with the people we care about. Thank you so much, everyone.
Thank you, Evan. Okay, so let me just pull up. Videos. I'm just trying to pull up. So judges, any questions for Evan?
Yeah, I'll start.
Go ahead, Chris.
So Evan, who would be your customer? What would be the profile of somebody that would purchase your services?
Great question. So the people who are going to be our customers are the labs. So that's people who are actually doing the test. So this can be a clinical lab, a CRO, a startup launching a microbiome service. Actually, one of the things that I think makes us unique is because we have a nimble and performance service, we can target people who are normally would have been a little too small for a lot of the traditional companies, but have a much faster sales cycle while still having an interesting ACV.
And how many labs out there? What's the size of that market?
Yeah, so I mean, so you're looking in the United States alone at tens of thousands of labs. So, there are between 10 and 20,000 CRO labs in the United States. There are, thousands of services that are doing different kinds of microbiome analysis. The way that I think of the market is actually the number of tests. There are over 2.5 billion microbiology tests that are done. And when I think of, us being able to take over some of that, I think of how a lot of these tests can be rolled up into one sequence. So existing tests are one microbe, one test, and one characteristic, one test. So if I want to look for, say, 5 different things, I have to do 5 different tests. And additionally, if I want to do an additional kind of test, say a virulence test, that's an additional thing. So sequencing offers a really interesting alternative. And you're not going to want to use sequencing for all those tests all the time. For example, if you really care whether it's alive, you're going to want to use a CFU. But nonetheless, we think that a majority of that will eventually be done with our software, empowering people to do sequencing.
Thank you.
Okay, we have time for just one more quick question. Go ahead, Edgar.
Evan, thanks for the pitch. You mentioned that your software is easy to use and fast. So what distinguishes you from the competitors? Do you have a proprietary algorithm or that's running the software? I'd be curious to know.
Great question. So what makes us good is our proprietary infrastructure. So our belief is that the science is good. So the core science part is done by open source libraries produced by some of the top labs in the world, the stuff that everyone else uses. But what we do is we think about how the data flows through the whole system. And so we built a really strong bioinformatics platform. The other thing that we think about that other people don't think about is the database. So sequencing is an extremely data intensive process. Most people deal with this by having a small database and they dress it up with the marketing term curated. What we do is we think about how to have the database maintained daily and across lots of different things, so we can have the largest library in the world, while also being really smart about how we use the data so that it still runs faster than everyone else. So we're a technology company, and we aren't trying to change the science of how people do genetic sequencing. The science is good. We're trying to change the engineering of how people deploy those solutions, if that makes sense.
Okay, so long answers. So for so we don't have time for more questions or feedback. So we do need to now switch to scoring for Evan. So judges, get ready to sort of throw up your fingers and give me a score from 1 to 5 for Drift Biotechnologies. So 1, 2, 3, go. All right, Gary's got a 3. We have a 4, 2 4s, a 3, and a 2. Great. Thank you, judges, very much. And thank you, Evan, for sharing Drift with us today.
Feel free to reach out with more questions. I'm on the Slack, and I'll put my email in the chat.
Fabulous. Great. Thanks. So next up, we get to hear from Heather Lagrippo from the U.S. Consumer Healthcare Advocacy Group.
Thank you so much.
Heather, so we can see you, and I think we can hear you.
Can you see my screen?
And we can see your slides.
Beautiful. All right, thank you so much. So as you know, my name is Heather Lagrippo. Our company is headquartered out of Alabama. You are correct. I am in Boston, actually, though. So with advanced AI data analysis delivered with a compassionate human touch, we are going to empower the consumer to take control over their healthcare like never before. So what's the problem? The problem, as we know, is 1/3 of the nation's healthcare spend is waste. 1 out of every $5 a person spends in this country, they spend on healthcare, and people do it blindly. It's their health. The problem is very complex and they just want to get better. There's another problem. There's health literacy. There's incorrect medical bills, gaps in insurance, complicated systems, confusion with legal forms, and endless scenarios that force a consumer to navigate a system of confusion and complexity to resolve issues. And there's an uneven playing field. As we all know, insurance companies are dictating the protocols to doctors and patients. Systems are confusing, and it's on purpose. It's so that the stakeholders in healthcare, sometimes they don't put the patient's needs first. And a lot of times it's impersonal. If you're very sick and you have to advocate for yourself through a very complex system, you feel very alone and you don't have a lot of help. And I know we're all here trying to fix that, but we would like to fix that from a global perspective. So what is the solution? The solution is concierge healthcare for everyone, powered by HM2, which is called Health Manager 2. It's a personalized advocacy platform for total healthcare. All the health data is in one place. We are able to give actionable insights in record time. There are no barriers for entry. It's not insurance at all. We use artificial intelligence, machine learning, and quantum processing. We combine all of that data with a delivery system of humans, and that brings you disruptive change. One of the really interesting things about the company is we have the first of its kind incapacitated living power of attorney, and that activates upon member sign up, and it allows us to act as if we are the patient, which circumvents all of the HIPAA issues. Okay, size of the market, it's enormous. Just 1 in 20 people worldwide had no health problems in 2013, and 1/3 of the world's population experienced more than 5 ailments, according to a major analysis. And of course, that number's increased. So the total available market, it's a $4 trillion industry. Serviceable, we can do about 10% of that, 4 billion, and 4 million is what we can obtain to start. And I'll tell you how we know that. Because we did beta. Over 6 weeks, we had 132 people sign up. They paid $9.99 a month for advocacy, and we made $31,000. And if you're doing the math, it might not make sense, and I'll tell you why. Our revenue model is a low-cost subscription. We have add-on fees that are aligned with additional value depending on what the patient needs. It's all customized depending on what your particular scenario is. So I'll give you an example. We made money by taking a percentage of medical bill savings. We're able to give up to 50-second opinions without leaving your house. There's a number of different ways we can monetize advocacy. The team, me, I started autotrader.com in 2000 and own 3 other companies. I'm a serial entrepreneur. Kevin retired after 30 years as a master chief in the Coast Guard. He's our logistics person. And Nate graduated Yale when he was 19 with an MBA and has already sold a company to SpaceX. So we are serial entrepreneurs. And our exit strategy, IPO, strategic acquisition, or partnership. Our goal is to build an enormous business that helps consumers take control of their own healthcare. When that is achieved, there are many, many options. Our independence and our data integrity is key, and that's because we only advocate for the consumer. We are not beholden to anybody but the consumer. So making sure that we have the sanctity of our data is the most important thing. Our ask is $750,000 to get to a minimum viable product, including 500 paying clients. How'd I do?
You're good. You're good in terms of time.
All right. Well, if I have a second, I'll tell you why I was really interested in starting this company and being a co-founder. And that's because in 2017, I got so sick that I almost lost all of my businesses. I couldn't talk almost for 8 months. And it took me 8 months to get diagnosed. In that time, I was called everything from crazy to stressed out, and nobody could identify what the problem was. And if I could get 8 months back of my life, which is what this technology can do, there is no price that is not worth. So that's it.
Great. Thank you, Heather. All right. Judges, I'm sure you have questions about this. So let's start with Balint.
Yeah, great presentation. Congratulations, and a really important problem to solve. My question is, how is your competitive landscape looks like? Direct competitors or even indirect competitors?
Yeah, so in the UK, there's a company called Babylon, which would be considered kind of a competitor, except for the problem is when they first came out, they went and they said that they were going to replace doctors, which we are never going to do. We're going to make the doctors' lives easier because we're going to handle all the interaction with the insurance companies, and we're going to make their lives so much easier. And so no doctors wanted to support them. And so they didn't do very well, and they're still kind of struggling a little bit. So that would really be our only competition.
And
Mo,
Go ahead, Chris.
yeah, I was going to say, actually, what about the whole carrier navigation industry out there, starting with Grand Rounds and Rightway and a whole bunch of other companies that are, that are all sort of, Series D-ish funded. How do they compare to what you're doing?
Yeah, so they're not using quantum processing to take massive amounts of control data and put it up against clean data, which is what's going to happen when we start to advocate. We can start to decode all of that data and combine it and use quantum processing to find entanglements that people would never know before. So they're not using it in the same way that we are.
So Heather, give a use case for a particular, application of the quantum processing to do what?
To do what? Okay, so I'll give you just a use case that we had in beta, and we didn't have, when we did beta, I call it our Frankenstein model. We took a bunch of existing technology and put it together, and we didn't use quantum processing. So we had to just test the efficacy of the product and if there would be a market for it. But we had somebody who came to us and they needed a new hip, and they thought that they were covered for 80% of their new hip. Come to find out, we did an analysis, they were only covered 30%. So we contacted their doctor, waited till open enrollment, helped them find another health insurance that was better for them, and then waited till after open enrollment and got them in and got them 90% covered for their hip. That's just one little scenario, but we could do anything from, if you have bills that are overdue, if you need help with med mal, we can help with that. There's, depending on what your situation is as the patient, that's where we can help you.
Okay. Any other questions?
Yeah, actually, I was just wondering, thanks for the pitch, Heather, very nice. So your beta users, what is the profile? I'm sure there's but they're probably very diverse, but could you maybe tell us a little bit more about who they are and where they came from?
It was all over the map, and they came from people who were, we just put out ads saying, like, do you have any medical issues? And we kind of broke it into certain categories. So we said, billing issues. Do you have problems with your pharmaceuticals? Do you have problems with finding a second opinion? We just kind of looked at all these end users and got them in and then started solving their problems individually.
So if you have one more second, how far along are you on actually creating your technology? Have you developed the AI yet, or where are you?
Nate is one of 67 people in the world that has access to the Q computer for IBM. And so it's ready. And we just have a development team that we have to pay to get it up and running. And that's really all we have to do.
I see.
Great.
Thank you.
Okay. Thank you, Heather. Let's shift to scoring from the judges. So 1, 2, 3, show us your scores. 2 4s, a 3 and a 2. All right. Thank you very much, Heather. It's really exciting. And next up, we have Dr. John Hsu with iPill dispenser. Let's see. So we need to see you on camera, Dr. Hsu. And to come off mute. Hello. There he comes. We can't hear you yet, Dr. Hsu, just so you know. It'd be great to hear you talk. We see your screen. We still don't hear you. There we go. Now I hear you.
Okay, is that better?
Yeah, we can hear you, and now we just need to see your slides.
Share your screen.
We see your screen. We just need to see your slides.
Okay, can you see the slides?
No, I see your screen, your monitor screen.
Okay, for some reason I'm not getting the right. Okay, I'm gonna go backwards again. 1 second.
Okay. Okay. Yeah, we're still seeing a big rock here.
Okay.
There we go. Now we see your slides. Okay.
Oh, that is so stressful.
We are ready to go when you are.
Okay. Thank you for allowing me to present. I'm Dr. John Su, CEO and co-founder of the iPill. I practiced anesthesia for 28 years, or actually it's 29. And in my practice, I found that it was impossible to monitor medication adherence in my patients. I couldn't tell if they were taking the prescriptions as prescribed or abusing them or even selling them. So the problem is, and I'm going to ask the judges, have you locked up your opioids today? The reason that's important is because 128 people die from opioid overdoses per day, and 1 in 4 opioid overdoses now involves children and teens. The real problem is opioids are not locked up at home. The same opioids are locked in the hospital, but they're not locked at home. The result is abuse, sharing, and overdose. And our target customer are people with opioid use disorder, and I'll discuss that in a moment. Our solution is the iPill dispenser. It's a drug vault that securely stores pills. What makes us different is that we destroy pills if tampering occurs, and we remotely destroy unused pills at prescription end. That means you don't have pills in your medicine cabinet hanging around for people to abuse and divert. The iPill app is a biometric key that operates the iPill dispenser. Only the person prescribed gets access at only the prescribed dose and time. This obviously can reduce abuse and sharing. The current iPill is an FDA Class 1 registered 510K exempt product we can sell today. Our future product is a FDA Class 2 designated breakthrough device. It adds a respiratory biosensor to the iPill app and dispenser. The respiratory biosensor detects opioid-induced respiratory depression, then terminates access for more opioids. And if the person's really in trouble, we will call 911 through the app. What's important and sets us apart from all the other dispensers out there is CMS announced reimbursement coverage for FDA designated products, which iPill is. That makes iPill the only dispenser covered by insurance. Okay. Technical difficulties here. We have 3 moving parts. It's easy to manufacture, 3 granted patents, 3 PCT patents. The market for the iPill dispenser is quite large. All addictive drugs can be used in the iPill dispenser. We're only focusing on the opioid segment because it has the highest overdose death rate. Senior management, we all have startup experience and we all have exits. We're supported by a strong board, advisors, vendors, which also include a former FDA director, Foxconn, the people who make the iPhone, and a couple of addiction treatment centers. Our revenue model is B2B sales. First target, addiction treatment centers. It's a $2 billion SAM. We have current traction with purchase agreements from 2 clinics. They want to reduce the 91% relapse rate and the $20,000 transportation cost to and from Suboxone and methadone clinics. We have 14,500 clinics to go. These 2 contracts could represent a revenue model of $7.7 million annually. Our COGS are 15, retail price is 50, and that retail price is market confirmed because these addiction clinics came to us wanting to buy it. We told them it would cost approximately $50 and they accepted. That means at 1% market penetration, that's $64 million a year, 5%, $320 million per year. We do have competition. We are cheap. We offer more features at less cost. Biometric authentication, destruction of pills, collection of data to add for medication adherence. We're asking for $1 million for a human factor study, completion of our prototype. This is an actual iPill dispenser that actually destroyed the tablets. This is what destroyed tablets look like. This is what it looked like inside the tablets, inside the iPill dispenser when it's destroyed. We're then looking for $2 million for an 18-month runway. Our exit. Now, this is the part that's most interesting to us. BD, Becton Dickinson, they have what's called a Pyxis device. That's a hospital-sized device, just like ours. We talk to them. We want to build a strategic partner with them to extend their hospital strategy to the home. That also means that they are our buyout partner.
Dr. Su, we're over time, so I'll give you, like, if you want one final statement or anything, but we need to wrap.
Sure. A final statement is, have you locked up your opioids today? Simple fix. We actually have a solution for the opioid crisis. Thank you very much.
Thank you very much. Judges, do you have any questions for Dr. Su? Go ahead, Gary.
John, good to see you again.
Hi, Gary.
I've heard your presentation before, and as a fellow anesthesiologist and physician, I completely get this. So my question is more, I see the use case here, and I think it's great. Do you see this expanding beyond opioids as an opportunity as well?
Yeah, we got a call yesterday from a company called KetaMD. They're using 6 lozenges for ketamine, and they just need to, instead of sending one ketamine pill overnight to patients, they're going to send the iPill with 6 devices. So instead of 6 times $30 for overnight expense, it's 6 times or 1 times 30. So it's purely a financial play. So they have a movie with Lamar Odin, and so we expect what they conservatively tell us is probably about 1,500 to 2,000 monthly sales of the iPill to them, just to send the lozenges from their compound pharmacy to the patient's homes.
Great, thank you.
Judges, any other questions?
Yeah, Dr. Chu, how do you destroy? How does the device destroy the opioids, and what happens after that? The opioid is destroyed to the material.
Destruction, DEA approved solution. The pink.
Whoop.
Dr. Su, we can't hear you. If you can maybe turn off your camera, maybe that'll free up a little bandwidth.
Be recycled. This is $15 to make in Mexico. So it's destroyed and thrown away in the trash.
Unfortunately, you kind of broke up there. Maybe if you could turn your camera off, and we didn't hear the answer.
It says my internet connection's unstable for. Did you hear the answer?
Yeah, turn off your camera.
Okay. There.
And then just answer the question.
Okay. Destruction. Let's see. What did you ask? Oh, destruction. DEA approved solution. Denatures the opioids. We encase it with a resin afterwards, and then it's just recycled in the trash can. It is. We have a PCT patent in the EU. We're going to the United States and Canada first. Those are the highest death per capita. So we will be going to the EU, but it'll probably be next year.
Okay.
Okay, great. So, all right. So let's thank you very much, Dr. Su. Let's go ahead and shift to scoring Dr. Su's pitch. So judges, if you can put up your scores for us. So we have a 4. Let's see. We have 3 4s and a 5. Okay, great. Thank you very much, Dr. Su.
Thank you very much.
And last but not least, thank you. We have Fabian Teme with medical cooling. So we see your slides, and you're putting it in presentation mode. Can you talk so we can make sure we're hearing you? No, that's okay.
Perfect.
Okay, we can hear you.
Excellent.
And we are ready to go when you are.
Okay, imagine this is your heart and suddenly it stops beating. Every second you lose tissue damage, and right now you have got a survival rate of only less than 10%. If you cool the brain below 36 degrees, you increase your survival rate by 167%. So you become to a survival rate of 24.4%. And in Germany, not even 1 in 4% of the patients are getting cooled in the hospital. In the ambulance, almost no patient is getting cooled. There's lots of science on it. It's in the medical guidelines. It's clear why the old method of cooling shouldn't be used, cold infusion, because it leads to new cardiac arrests. But, and of course, you can save some babies with this also with lifelong brain damage. So why it's not done yet, it's because of the reimbursement system of the ambulance. The ambulance basically gets paid for the kilometers they drive and for the general treatment. It's the same all over the world. It doesn't matter if you're in China, mainland, or Taiwan, if you're in the US or if you're in Germany. All the time, the rates are not increased for an improved treatment. So this is a major issue that's global. And this is how we got into telemedicine, because we need some type of reimbursement to make it, to give some additional benefit to the paramedic, because of course it's nice to save a life, but at the end of the day, they need to be reimbursed for it. And right now, with the up-to-date reimbursement systems, it's not possible. And also we need lots of clinical data. So we want to collect it automatically. And it's really easy to do an automatization of lots of the documentation, where we did just finish the side project yesterday to automatically detect COVID tests. And for the patient, of course, if you add telemedicine in the ambulance, you can improve the treatment. You can get great advice by experts, and you can pre-book into hospital. So you can get the patient to hospitals that actually has treatment capacities. So our telemedicine platform has a video stream function within MD, and the policy information, which is not that special. We can provide video tutorials. For example, if you need to get a catheter into the direct lung to release pressure. We have treatment question trees. If the paramedic don't know what's going on and needs some advice, we have an AI-based suggestion of treatment examination. If the patient doesn't, or the paramedic doesn't know what's going on, a prediction of the patient development. So if the patient is able to get to the hospital, clinic suggestion and booking, and patient information, especially if all the patient data goes to the health cloud, it would be helpful if the paramedics have access to it, especially pre-existing conditions, and the medicine the patient takes is often important to get the right diagnosis for the patient. And the billing is things that's still done on paper and pen, and where's the big benefit in automation. Right now, our roadmap, we are financed until July 2021, where we can only develop ventilator-specific features, and we will have a VR demonstrator and training simulator later on, I think already in June. We're not yet financed to do all the fancy stuff, the certifications, and we need another 19 months and 3 million euros to get our device CE and FDA certified. This is our device. We will replace the existing ventilator, vacuum pump, ECG, and defibrillator. And we've got 5G telemedicine and AI assistance, which you can also find in different devices, but which is not widely rolled out yet. And which are special, we've got new protective improvements, 1 times the hypothermia, and we've got argon and xenon on top, so we can even reduce brain damage more. So we get out the patient as healthy as possible, because brain damage is really expensive. And we could show that there is a saving later on in the treatment. but the savings that is 4 days later in the hospital cannot be transferred money-wise to the ambulance company, which is our biggest issue right now. So we've got some political barriers to overcome. We've provided cold air and have got the connectivity to the healthcare cloud and whatever. So we've got one device that can cool and do the monitoring. Soon you will can experience yourself in the VR world why 5-in-1 makes sense. And this is basically the solution I'm presenting, and I'm up for questions.
Great. Thank you, Fabian. Judges, questions? Go ahead, Gary.
Yes. Wow, that was a lot to swallow, even for an anesthesiologist.
Yeah.
I mean, I know a lot about brain cooling. So I guess I mean, I could spend 3 hours with questions on this. But so what is who is your end client on this? So is it a hospital? Is it, I mean, who is it?
The end user is the ambulance, and we try to make the end customer an insurance or a government, because the ambulance doesn't have much benefit if the patient survives way better, and they don't have any difference in the reimbursement if the patient walks out of the hospital 3 days later or if they are dead 3 days later. So we need to get the costs somewhere moved earlier to the hospital or to the healthcare system or to the government. Mostly it's governments that pay for ambulance stuff.
And just one other quick one. So is there any downside? Like, what if it's used in a situation where it's not indicated? What are the downsides of initiating care?
Dry lips. You get really dry lips, but consider to death or strong brain damage, dry lips that go away half an hour later are a good side effect.
Okay, thanks.
Any other questions, judges?
Hey, Fabian, good to see you. I have a question. So you mentioned that you're doing your clinical validation right now. Where is it happening, and where are you along that way?
I think I already even showed you the clinical validation. We did it at the Hamburg University Hospital in Eppendorf. This was already done. Right now, we've only got a small finance series of $250,000. And right now we just do ventilator parts, but the clinical validation is already published with temperature MRI and in human use.
Fabian, one of the things that you, go ahead, Balint.
Yeah, thanks. Really great presentation and exciting technology. My question is about the similar solutions. So what should we know about the similar solutions?
Our competition, our competition is right now basically to not cool the patient. There's one company from Sweden that would have a usable device called RhinoChill, but they've got an extra device which is not really user-friendly, and we're the only companies that replaces existing devices. And from a user setting, it's impossible to use any extra devices if you want to carry them to the patient. So in hospitals, there's already good cooling solutions, and it's done in many hospitals in a good way. But in the ambulance setting, there is no cooling solution yet that is wider spread. So this is an open market. Our main issue is that there's no budget, and this is the same issue our competitor faces. We need budget for an approved treatment, and we need around 900 euros per life saved. So we've got
Yeah, thanks. And what's easier from a business perspective, replacing existing solutions or somehow augmenting them?
We can match the price of a existing ventilator and ECG. And for us, it's basically to be guideline conformance treatment. For newborns, there is already a law firm in the US that's doing lots of claims. And for newborns, we got some progress through some competition in the US. So there's lots of happening. We think if we make it to the market and get the FDA clearance, we will be able to set up claims against ambulances that don't cool the brain and where patients have lots of brain damage or death. And this is far more expensive than 150 euro treatment. And this is one of the market entry strategies we will go for the US. in Europe to make a claim because somebody has strong brain damage or died is not really worth the money because reimbursed or the claim amounts are not really high. We are right now focusing on Asia and US in the subject.
Thank you.
Okay, so judges, thank you very much, Fabian. And judges, we now need scores for the medical cooling pitch. So 1, 2, 3, let's go. We've got a 2 and a 3, 2 2s, a 3 and a 4. Okay. All right, so I'm gonna let Savannah and the team behind the curtain sort of tally things up for me for the score. Savannah, if you can send me the name of the winning startup. I think I know it, but I just wanted to double check. So first of all, we want to thank all of the startups for taking the time to pitch today and to share what you're working on to make healthcare better. We know there's a lot of blood, sweat, and tears and passion going on behind the scenes to make these things ultimately get to patients in the healthcare system. So thank you for sharing that with us. And judges, thank you for your insightful feedback and questions for these startups. So want to remind you all again that nobody walks away empty-handed, as all startups participating in today's session are eligible for a free product boost session with Bene Studio. And then the prize, again, for the winning startup is a one-on-one coaching session, courtesy of Runway, and also a product boost and product acceleration with Bene Studio. The winning startup will be highlighted as the HealthTech Startup of April with an exclusive interview that is published on the HealthTech Networking Club page and across the Bene Studio media channels. So it's always great to get some social media love. And so the results are in, and the HealthTech Startup of April is iPill, Dr. John Su. So Dr. Su, we let the winning startup have the opportunity, if you want to take it, to have a final comment or even ask to the audience.
Well, thank you very much for the choosing iPill. I think that above and beyond the business, this is something that the society needs. So we hope that we can work together in the future to make this commercial product on the market as soon as possible. Final comment is that we are going to clinic in July, August. So we should have this in the market in end of quarter 3, beginning of quarter 4.
Terrific. That's great news.
Thank you very much,
Dr. Su. Thank you. All right. So thank you everyone for attending the HealthTech Startup Awards. And of course, a big congratulations to our winner, iPill. The HealthTech RapidConf April event is hosted by the HealthTech Networking Club. And for more information on this invitation-only networking club that connects startups, investors, healthcare providers, and other key players in the health tech industry, please see the Rapid Conferences and more information on the Bene Studio website, and follow Bene Studio on your social media. Next month, we're doing it again on May 27th. And also there's the focus for the great panel discussions that Lindsey Williams runs is on AI and machine learning. So another fabulous Rapid Conference is planned for May. And please feel free to keep, for networking club members, keep networking with each other on Slack. Have a great day and see you next month.